Good morning, ladies and gentlemen. I warmly welcome you all to yet another CPT webinar series organized by Sri. First, I will start with explaining the housekeeping rules to all of you. The webinar link will be available from 9 a.m. to 9:45 a.m. to join in. No late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for the CPT points, and the CPT points are strictly adhered to the NCCPT guidelines. This is to improve and maintain the standards of the CPT program conducted by Sri. Again, I would like to thank you all for strict adherence of the CPT regulations and for your kind compliance. I would like to also remind all of you to keep your mics muted and videos switched off at all times. Today, we will be discussing a very important and timely topic, which I am sure all of you will find very interesting and useful to you all. The topic today is polycystic ovarian syndrome, a systemic approach to manage disease and cater individualized patient requirements. And to discuss today's topic, we have Dr. Mithree Chandrarathna, consultant obstetrician and gynecologist attached to District General Hospital, Mathura. And if any of you have any questions or queries, you can type it in the chat box below. Please change your chat settings to all panelists and attendees so that your questions can be answered. And if you have very specific questions about your situation, please email us on officeshri@gmail.com. Without further ado, let us commence with the discussion.
Good morning. I'm going to talk to you about the polycystic ovary syndrome, a systematic approach to manage disease and cater individualized according to patient's requirement. I'm Dr. Mithree Chandrarathna, consultant obstetrician and gynecologist, District General Hospital, Mathura. So I would first introduce about the topic and give the definition of polycystic ovary symptoms. Then I'll be talking about the pathophysiology, management principles, investigations, as diet and exercise are main factors, key factors that needs to be corrected about diet and food habits, and the spectrum of disease. Just walk through the spectrum. So polycystic ovary disease is the commonest endocrinological disorder of the reproductive age group. The incidence is worldwide rising. So it's a heterogeneous collection of signs and symptoms. At the one end of the spectrum, there won't be clinical findings, but it's just a polycystic ovary ultrasonography. On the other end of the spectrum, you get the whole heap, the severe form, where obesity, hyperandrogenism, menstrual irregularity, subfertility, risk of endometrial cancer. So polycystic ovary syndrome leads to a significant reduction in health-related quality of life. So the spectrum, it starts with adverse lifestyle and inactivity, which leads to obesity, more and more fats. Then there is hyperinsulinism, and then there is insulin resistance, and a rise in leptins secreted by fat cells, signaling early menarche. Thereafter, you have the polycystic ovary syndrome. Spectrum can vary from person to person. Then pregnancy complications, gestational diabetes. Thereafter, prediabetes, diabetes, and leading to cardiovascular disease. So, to define polycystic ovary disease, out of the three criteria I'll be mentioning, presence of two criteria is essential. This is also called Rotterdam criteria. So oligo and or anovulation. So there wouldn't be ovulation at all, or there'll be ovulation will be less, which will in turn, the patient will present as oligomenorrhea or amenorrhea. Then hyperandrogenism is clinical features. So they can come with hirsutism acne and or biochemical elevation of, so the biologically we can see the testosterone elevation. Then ultrasonically, polycystic ovaries is 12 or more follicles or increase ovarian volume 1 cubic millimeter. So before coming into conclusion, other causes of the etiologies of hyperandrogenism and menstrual cycle irregularities should be excluded by appropriate investigations. So the polycystic ovary, it is partly known and much of it is still under research. So the hypothalamus-pituitary axis. So the hypothalamus controls pituitary by gonadotrophin releasing hormone in a pulsatile manner. The pituitary will secrete LH or FSH. The normal person FSH more than LH, and the LH and FSH cause steroidogenesis and follicular development, while LH will cause androgen production, luteinizing and androgen production. Thereafter, then what happens now is, so with weight gain or obesity, there will be insulin resistance. So the serum insulin level rises. At the same time, the resistance increases. This insulin, high serum insulin, modulates gonadotrophin production, which causes rapid GnRH pulse release, which in turn disturbs pituitary LH-FSH production. So FSH remains normal or elevated while LH is highly increased, which causes a reversal in FSH-LH ratio. Then the LH will promote androgen production from ovaries, and LH will facilitate adrenocorticotropic hormone action on adrenal glands. So there will be increased androgen production. This increase in androgen production again modulates LH-FSH production. The androgens exacerbate insulin resistance. It is thought it could be mediated via insulin-like growth factor and the binding proteins. Many theories are there. They are still in research. On the other hand, hyperinsulinemia promotes androgen production. And this associated with this is some of them have hypothyroidism coexistent, and 15% of polycystic ovary patients are transient hyperprolactinemics and are permanently hyperprolactinemic, while up to 40% can have transient prolactinemia. So the pathophysiology is insulin resistance reduces sex hormone binding globulin, which increases the free androgen index, which facilitate 5-alpha reductase conversion of testosterone to DHEAS, dihydroxyepiandrosterone sulfate, which is a very potent form of androgen, which occurs in the peripheral cells. Now, management principles. So, in most of us would have seen enough polycystic ovary patients in our practice. So there are main, whatever the way they present, whether they are early menarche, with menstrual disorders, with subfertility, or they come for contraception, subsequently for abnormal uterine bleeding, the management with weight, BMI reduction. So appropriate the weight for the height, or if the BMI is in an adverse range already, correction of BMI. So the BMI correction should be based on three principal features, especially the physical activity of the person. And second, whether there are coexisting medical conditions. And the third one is age. So then the medical nutrition therapy. So depending on the person's lifestyle, that is activity, weight, and the medical nutrition therapy calculates separately the amount of total calories, out of which then the protein intake, what the carbohydrate, fat, and the fiber intake is. As we all know, PGM has a special course for nutrition, and for better management, rather than just prescribing a diabetic diet, it is better to refer them unless they are able to correct with normal advice. Then that is where the counseling is important. And coexisting endocrine disorders must be excluded. So the hypothyroidism, type 2 diabetes mellitus are coexisting with hyperprolactinemia. So what are the investigations? How do you confirm androgen excess? So the total testosterone level increases when the free androgen level increase because the sex hormone binding globulin level drops due to action of insulin. So the other causes of excess androgens are congenital adrenal hyperplasia, where 17-hydroxyprogesterone levels and followed by ACTH stimulation test. Next is androgen secreting tumors will have DHEAS being high, and imaging techniques by ultrasound, CT, and MRI will help diagnosis. And Cushing syndrome, mild to Cushing may behave like polycystic ovary in the early part. So 24-hour urinary free cortisol followed by overnight dexamethasone suppression test and measurement of cortisol in the morning. So when there's amenorrhea, you can do, if you're suspicious, can do LH, FSH levels and find LH being more than FSH, reversal of LH-FSH ratio. The other causes of amenorrhea, hyperprolactinemia, and thyroid disorders. The serum prolactin, TSH, and free thyroxine levels could be done. Then we must also think of autoimmune causes of ovarian failure. Resistant ovary syndrome, premature ovarian failure. So serum FSH, if it is very high, if it is more than 25, even 15 is quite high, more than 25, then the ovarian, there is resistance. And serum anti-Mullerian AMH level, anti-Mullerian hormone will help. Insulin resistance can be further detected by doing serum fasting insulin, fasting blood sugar. In type 2 diabetes mellitus, so to differentiate, and HbA1c, the tests that need to be done are fasting blood sugar, fasting insulin, HbA1c levels. Then we need to exclude hypothalamic and pituitary abnormality by doing CT or imaging techniques, MRI and FSH, LH levels. Now, as I have mentioned, dietary principles are most important. These are basic principles that we need to convey to the patient. That the patient needs to consume variety of different foods. The reason being, we are going to cut down on certain types of food, which may lead to certain forms of nutritional deficiencies, and control the portion size. Now, one is the single small portion, that is small portion, multiple meals are preferred. So, for example, if somebody takes a heavy lunch and a very heavy dinner, it is better to have 4 meals, for like morning, breakfast, lunch, evening, and dinner. So smaller proportions, multiple meals. Then the carbohydrate, basic principle is carbohydrates have to be in moderate amounts to supply energy, not excess, and high protein content with a high fiber content. The importance of high fiber content is with other reasons is to keep the stomach full, and it takes time to digest, and the patient will feel full and not wanting to eat. Then avoiding refined sugars is very important. Plenty of fruit and vegetables. Fruits and vegetables, especially fruit, you will see, and fruits, vegetables, nuts, as I go on with my presentation. Then fluid intake is very important, and not to skip meals. Now, regarding fat, animal fat is not good. The reason being, it has less, saturated fat is more in animal fat. So we have to reduce animal fat. Then more unsaturated fat. Unsaturated fats are found in the in vegetables containing food, and cashew nuts, peanuts, Ceylon almonds, which is known as cotton, pumpkin seeds, gingerly, and avocado. Now the issue here is, we know the cost of some of these nuts, how affordable it is. Then fish oil is good, as it has polyunsaturated fatty acids, omega-6 and omega-3, and monounsaturated fatty acids, which enhance HDL. Now, deep frying and refrying is not good, because fish, it can be converted to trans fat. So very important is the fact that this fish oil, this frying with vegetable oil, frying and refrying, which will convert unsaturated fat to a trans fat, which is not good. Coconut oil, although a saturated fat, can be deep fried and refried. and it doesn't convert to trans fat. Now, in medical nutrition therapy, they calculate the person fat and amount of fat needed, and they will go on to subdivide it into what type of unsaturated, what amount of fat you need to take, and the percentage and the breakdown, how much of saturated, how much of unsaturated, and the cholesterol intake, how much should be, is given in this chart. Now, Professor Ranil Javadana has made a model for my rice plate model for Sri Lanka. In this, the plate is divided into 4 quarters. 2 quarters will form 2 segments. Each, that is one quarter, 1 segment, second quarter, second segment. The balance half is divided into 3 segments. So 3, 4, 5. So 5 segments and 4 quarters. In this, he mentions that 1 quarter should be rice. Actually, what he really means is it should be carbohydrates. So we can give rice and wheat and yams into this 1 quarter. The other quarter should be proteins. So it is not necessary. It can the better proteins are animal proteins. However, that is formulated vegetable proteins with high protein content can be put into this category. So out of the other 3 segments, 1 segment is for dark green leafy salads, which we call mallum. And the 1 could be used for legumes and pulses. And the other 1 could be used for vegetables. So these are some of the yams that I have just brought some pictures. So I will tell in Sinhala, that is Innala, Kiriyala, Rajala, Hingurala, Manyokka, Batala, and Hulankiriya. And we have the Sri Lankan heirloom rice varieties, also known as Deshiya Hal, Kurlutuda, Suandal, Kaluhinati, Suduhinati, and Godahinati, Panchaperumal, Gonbaru. So these rice, this heirloom rice has more protein, more fiber, less carbohydrates, and with normal content of unsaturated fats. So they are better than the form of rice that we usually consume. Now, this is the other group chart where in medical nutrition therapy, the food is divided into according to the glycemic index, low glycemic index, intermediate and high, and each food group. So the group is further. So the fruits and vegetables, which has a low, medium, and high. So cereals, then breads, rice, pasta. So like on what will have the same thing, what form will have more glycemic index. And also, as I have mentioned earlier, the amount of food you use. So the higher the amount of food you eat, higher the glycemic load. So it's not only the index that is important, it's the quantity also what you eat. Then when it comes to losing excess weight, again, is a very tricky. Patients when they come to, they have already tried, they have done all, they have gone to gym, they have done yoga, then they are gone to exercise classes. So this should be tackled very carefully. After a very careful history, individualized basis, lifestyle modifications, and medical history. So there may be coexisting hypothyroidism causing this issue. So diagnosing and investigating, diagnosing, and treating other causes are also important. Then appropriate exercise program, because please consider about coexisting medical conditions if they are present. And the exercise program, for example, a schoolgirl, or it's a university student, office worker, garment factory worker, has to be punctual. You cannot ask somebody to do exercise while you are working or studying. So a practical approach to exercise program. And losing weight is very difficult if like, for example, university students or doing a job and boarded and they are forced to eat what is given by the house, or again they are in a hostel or a boarding where they have no option than to eat what they are given. So please be mindful when you get the history. So the social history and what the occupation, where they stay, all these play a very important role. And the weight loss has to be a realistic loss. That is over a week, maximum 1 kg, 500 grams to 1 kg. And no point giving unrealistic. Patient will get depressed and the patient will give up the program. On the other hand, a rapid loss of weight can disturb the menstrual cycle quite significantly. Now, there are drugs, anti-obesity drugs, orlistat, polycystocymine, pancreatosymine, hormone complex inhibitors. So the patient will lose fat with their feces. So fat absorption is reduced. Now, there are issues with timing of taking the tablet. So if you give a university student or office person who works to take the tablet during daytime, they will have to find a toilet and the back passage will be oily all the time. That will stain underwear. The timing of the timing of giving the drug, and that how often you give. Then Phaseolus vulgaris, seed extract, reduces carbohydrate extract, is a natural product and has shown quite effective. Then now leptins have come up as an anti-obesity, commercially available leptins. I will talk about leptins and liraglutides in my next slides. Then bariatric surgery. So there is a whole lot of research going on about leptins, and I can list so many, but I just picked up the important ones for this topic. So basically, it's secreted by fat cells and it's encoded by OV gene. So it's a peripheral signal. So how does the hypothalamus know about how much of fat this woman has? This signal is given from the peripheral fat cells. The fat cells produce leptin, which is circulated into the hypothalamus, and the hypothalamus now knows about the level of leptins in the body. And the leptins inhibit the satiety center, so the food intake. Okay, now that's enough. That signal comes from leptin. And in obese women, serum leptin levels are higher than other women. But what is the issue? Unfortunately, so technically, when the leptin levels are high, we expect obese women not to eat. But practically what happens, this is like hyperinsulinemia and insulin resistance. Same way we have the serum leptin level is high, but there is resistance. there is leptins are widely present in the reproductive tissues, but its relationship to reproductive hormones are not exactly known. So one of the main key factors weight reduction programs fail to achieve success is when you lose weight, your fat level drops and your leptin drops, and the satiety center inhibition by leptins is lost. So the patient will want to eat. Then comes, so, and also as I mentioned earlier, the signal for menarche is thought to be from leptins. So childhood obesity can lead to precaution or early puberty, early menarche due to leptins. Now we have glucagon-like peptide 1 agonist. So glucagon-like peptide 1 agonists, they are liraglutides and semaglutides. And so there you can have a profound weight loss in diabetic and non-diabetic patients. And now this is widely experimented as a drug, especially in a subgroup of polycystic ovary syndrome patients to lose weight. And we have two types. The dry polycystic or wet polycystic is one way, or the obese the obese patients have insulin resistance and high leptins, whereas the non-obese patients who are polycystic have androgen excess. Now, what are the next step is, we know there is hyperinsulinemia and insulin resistance. So how are we going to tackle this? Insulin sensitizing agents, so this serum insulin, which will reduce serum insulin levels, thereby improving symptoms of PCOS. So metformin, a biguanide, inhibit hepatic gluconeogenesis, therefore reduce insulin secretion. And it also enhances insulin sensitivity at cellular level. So the peripheral tissues take up sugar into the cell. And metformin reduce appetite. Therefore, the load of carbohydrate taken will be reduced. And so when metformin can be adjuvant or in combination with weight losing programs and lifestyle with exercise. So it can be combined with exercise and weight reduction programs with food. There, so, and as polycystic women have impaired glucose tolerance or type 2 diabetes, metformin can be used concurrently. So it has a better defined role. Metformin, continuation of metformin once pregnant will increase the chance of a live birth, because when the sugars are controlled, the mutations will be due to multiple reasons, the miscarriages will be indirectly reduced, and this will cause a higher live birth rate. In anovulatory polycystic ovary syndrome, there is a limited role, not directly as ovulation induction, but by reducing the insulin resistance, it improves ovulation rates and pregnancy rates, especially live birth rates. And if you're giving ovulation, direct ovulation drugs for ovulation induction, they need to be monitored very carefully by ultrasound scan, follicle tracking, and to see whether there is ovarian hyperstimulation. So by giving metformin, those risks are not there. And also by the actions given above, the ovulation induction drugs can be used at lower doses, not at higher doses. And the response is better, side effects are low. When it comes to ovulation induction side effects, I'll be discussing later. Now, inositol is glucose oxidase in the one of the components or metabolite of glucose oxidase pathway. Then it has a major role in ovarian function. So there are 9 isomers in the reproduct. So it is a myoinositol and dechirioinositol, DCI. Myoinositol is also written as MI. So what is for the other 2 widely researched and isomers? Myoinositol is widely distributed in nature. So in abundant in ovaries and follicular fluid, and specific role in insulin signaling and follicular development. That is one of the reasons why we have now inositol. We supplement inositol when the ovulation response is poor for ovulation drugs, or if the patient is unable to tolerate or has side effects due to ovulation induction, inositols are very helpful. So this is part of they are in the pathway of insulin signaling follicular development. So myoinositol stimulate FSH signaling as a second messenger, whereas dechirioinositol is responsible for insulin-mediated androgen synthesis. So it acts as an aromatase inhibitor. So is a conversion of testosterone to 5-DH, the DHEAs, or conversion of estrogen to testosterone is reduced. So inositols, as I mentioned in earlier, fruits, beans, grains, legume, that is, fruits, legumes, pulses, and nuts. This is how the FSH myoinositol acts on the granular cells. Then the androgen conversion to estrogen, aromatization, and aromatization of androgens to estrogen is facilitated. And the LH theca cells action, where cholesterol to androgen conversion is facilitated by chirioinositol, dechirioinositol. Now, when it comes to physical health activities, it's just very simple. We can be explained that to do at least 30 minutes a day. And there's no reason why you should do 30 minutes continuously. It can be interrupted into at least 10 minutes, 10 into 3 times. And aerobic activity, walking, running, jogging, household work, etc. And vigorous are also important to build up muscle mass, because the fat, the body fat, we can get rid of body fat and replace them with proteins. And mostly, as doing physical activities alone is very boring, organized activities are better than single activities. This is a representation of, again, vigorous, what the moderate intensity physical activities, and what the vigorous intensity physical. Then, who manages this person? In the past, it was mainly the gynecologists who managed this problem. Now, with the increasing in lifestyle, that is the bad dietary habits and lifestyles, it is better the nutrition, the weight reduction and the nutrition part is handled by a specialist in nutrition. We have seen endocrinologists are now managing these patients. However, we have seen some of the endocrinologists have crossed their boundaries and have started drugs for ovulation induction without adequate follow-up, as it is better always for the person who prescribe a drug to do the scanning, the gynecologist. We know how to detect ovarian hyperstimulation syndrome very early, and we can reduce gaps in communication. Ovarian hyperstimulation, severe ovarian hyperstimulation can be lethal. Patients can die. On the other hand, you might have unwanted multiple pregnancies unless properly supervised, and overdoses there. And there are now, once the metabolic syndrome develops, dyslipidemia, hypertension, diabetes, the physician comes into role. And if the physician doesn't or manage the patient well, then comes the cardiologist. And if the gynecologist doesn't manage the condition and prevent hyperplasia, dysplasia, anaplasia, and which can lead to cancer, then the oncologist will come. And there are cardiologists. I think if we don't manage patients well, we'll be supplying cardiologists bulk of their patients. And the psychiatrist role is very important, because most of these people are tired of going from doctor to doctor. They go on doctor shopping, expecting one doctor to be better than other. And ultimately, they give up their distress. So now I'm going to take you through. Imagine you have a woman, a young girl, coming to you, and different parts of this girl's life, different phases. For example, teenage. Then she might come newly married for contraception. Thereafter, after some time, or maybe very early, they want subfertility. Then maybe followed by, again, they might come for need of contraception. Thereafter, unless we have managed the bleeding and the estrogen, the condition well, they will come with endometrial carcinoma. So now I'm talking about the one end of the young girls, the teenage girl presenting. How will they come to? One is amenorrhea or oligomenorrhea commonly, or amenorrhea, or features of hirsutism and acne, and sometimes hair loss, alopecia. So we must not diagnose polycystic ovary until 2 years after menarche, because up to 2 years, it could be irregular cycles, and there could be ovulatory issues. So other than now, first I'm going to, so what are the drugs used in irregular cycle. So for heavy bleeding, tranexamic acid could be used to control the cycle if it is erratic and disturbs the girl's lifestyle. Combined oral contraceptive pill or cyclic progesterone usage can be supplemented during certain days of the menstrual cycle can be done. Now, giving oral contraceptive pills to a girl of this year is a big social issue and which is not acceptable to most of the parents. And physical treatment, vaccine, shaving, electrolysis, and bleaching are physical ways of getting rid of hair. And furthermore, laser and photothermolysis, they are more expensive, but their duration of action is longer. Then there is eflornithine, irreversible inhibition of ornithine decarboxylase in skin. So therefore, there will be reduction in hair growth, especially face. Unfortunately, there can be thinning of skin as well. Then to regulate the cycle, we can use pills containing estradiol in combination with a progestogen or cyproterone acetate if there are marked and hyperandrogenic symptoms, androgenic. And in the good old days, spironolactone was used, 25 milligram to 100 milligram. There is research going on in about finasteride role in hyperandrogenemia in patients with PCOS. So the summary is, if the menstrual condition bothers her, treat it. But basic weight reduction and dietary advice is important. Sometimes irregular bleeding does not respond to low dose estrogen. Sometimes there are instances where we have to use high dose estrogens for a short while. When there is amenorrhea or oligomenorrhea and with coexisting menstrual irregularity, low dose combined OCP, which I have already mentioned, or cyclical progesterone can be used. Now, a woman comes seeking advice for contraception. Now, again, whether there's a newlywed couple needing contraception or after first child or the second child, a detailed history is important. And whether there is coexisting menstrual irregularity is of utmost importance. Now, if they are not happy for hormonal contraception, barrier methods, condom is available. But when there is coexistent menstrual irregularities or oligo or amenorrhea or erratic cycle, erratic menstruation, it is easier to use combined oral contraceptive pills regularly, maybe at least for till the time she needs it, to regularize the cycle with contraception. So there are two benefits, contraception and the cycle is regulated. Then when we come to the estrogen component, low dose estrogen, lower the dose, less side effects. Lower the dose, cycle control can be a problem in obese patients. So when the BMI rises, it is better to increase to select OCP with a high estrogen level. So we can use 20 or 30 micrograms. Then there is 35 estrogen, 35 micrograms, which I will talk to you later. Then the COCP has the progesterone component, different molecules, noethesterone, desperinone, or levonorgestrel. So each of these progestogen has their own, can have their own side effects. Then cypraterone acetate with estrogen 35, cypraterone acetate combined with OCP with 35 micrograms of estrogen. Then, so dipomedroxyprogesterone acetate for recommended for second para or with one child or with other options like implants, contraceptive implants, Implanon, Jadel, Norplan, Sino implant. So these are types that you can recommend it, but in a teenage polycystic ovary where there's family support is poor and they are financially also compromised, contraceptive implants can be used to increase the compliance. Then giving dipomedroxyprogesterone acetate and implants for teen patients can exacerbate or cause de novo menstrual irregularities. Copper UCD and levonorgestrel I use the intrauterine system are quite beneficial as but this is mainly for patients if who have regular cycles, and the LNG IUS is recommended very suitable for patients with irregular cycles as it thins the lining of the endometrium and reduce bleeding up to 30 to 60% in first 3 months and 60 to 90% in second 3 months. Now, FSRH and the European guidelines recommends intrauterine system and copper UCDs can also be used for teenagers and adolescents. Now, next we get our subfertile woman. The part of the spectrum is maybe primary subfertility, maybe would have had few miscarriages, or first child she would have had when she was young, and secondary subfertility. So it depends, a careful history. Then, as mentioned earlier, very important medical diet, that is medical nutrition therapy and exercise. Thereafter, we ovulation induction. So lifestyle modifications, diet, exercise, then insulin sensitizing drugs, metformin. Thereafter, for ovulation induction, traditionally, clomiphene citrate has been used. So it has been, clomiphene citrate has been used as a first line. Ovulation approximately 70 to 85%, and within 6 ovulatory cycles, 60 to 70% gets pregnant. But it is very important, it is a must that they have serial ultrasound measurements of follicular growth to prevent the risk of ovarian hyperstimulation syndrome, if severe, can kill her. Then aromatase inhibitors, letrozole. The mode of action is it prevents aromatization of estrogens, and in turn it will stop the negative feedback effect. So now WHO recommends letrozole as the first line of treatment. With compared to clomiphene citrate, less side effects on the endometrium and cervical mucus. So the clomiphene citrates has adverse effects. It reduces endometrial receptivity and makes the cervical mucus thick, making sperm transport difficult. And with letrozole has higher pregnancy rate compared to clomiphene citrates, letrozole reduces incidence of multiple pregnancies. However, there is a minor risk of congenital anomalies. Then, if letrozole and clomiphene citrate, the next therapy is parenteral, that is injections of gonadotropin. So there can be FSH. Purified FSH can come in a form of urine, that is highly purified or highly purified urine FSH, or recombinant DNA. So you can have then if you are using FSH, needs HCG for ovulation. On the other hand, human menopausal HMG, human menopausal gonadotropin, can be used. There are different regimes. Low dose our setup, so can follow the regime whatever you are used or recommended. And the ovulation, once ovulation is triggered with FSH, we follow it with HCG. So if there is hyperstimulation, HCG injection should be avoided. Next step is laparoscopic ovarian drilling. The 4 diathermy points. So laparoscopic ovarian drilling, the injured ovary will stimulate the contralateral ovary by way of cytokines to increase ovulation. So this will, in the long term, cause restoration of ovarian activity and decrease in serum LH and testosterone levels. But with time, the efficacy drops. And the advantage has been it's free of multiple pregnancies. There is no ovarian hyperstimulation syndrome and does not require intensive ultrasound monitoring, unlike with clomiphene citrate, letrozole, or GNR. Especially with you are using FSH or HMG, ultrasound monitoring and close follow-up is very important. The side effects or the disadvantage of ovarian release is overheating can destroy the ovaries, so ovarian failure, and the risk of additions, and the surgical and anesthetic risk. If FSH levels and AMH can be done before ovarian release, it is not mandatory, it is not done, as AMH is costly, and doing both, at least even FSH, is not cost effective. It will be useful, especially people who have lower reserves. Now, if a woman, this same woman now pregnant, our subfertile patient comes, so then she has the risks of early pregnancy loss, risk of gestational diabetes mellitus, followed by PIH and preeclampsia, risk of preterm delivery. Please note risk of preterm delivery, and high incidence of cesarean sections. So this type of women needs to be seen by consultant in obstetrics, very under very close supervision. Aspirin is useful, prevent miscarriages, thins the blood, and help in reduces placental thrombosis, thereby reducing miscarriages. And early aspirin supplementation cause the trophoblastic invasion of the myometrium is facilitated further. So this type of women, again, closely following up blood sugars, checking cervical length ultrasonically, then the screening or having a very close blood pressure monitoring is important. Now comes a middle-aged woman who has completed her family, comes with abnormal uterine bleeding. Now she has no fibroids, no endometriosis, adenomyosis, no polyps, pelvic inflammatory disease, or ovarian cysts. So what are the risks she is faced with? The metabolic syndrome. So type 2 diabetes mellitus and metabolic disorder. Cardiovascular risk assessment by way of blood pressure, BMI, thereafter lipid profile, ECG. Cardiac assessment by way of echocardiography or angiogram. There is coexistent obstructive sleep apnea, snoring during daytime, fatigue, somnolence, and finally, this is where our psychiatrists get involved. They have psychological issues, depression, anxiety, and eating disorders. Now, when there is abnormal uterine bleeding, up to 80 to 90% can be normal. It may be 10% malignancy or maximum another 10 pre-malignant conditions. After ultrasound scan, endometrial biopsy is much needed. It could be done by non-invasive methods of pipelle biopsy or under anesthesia, dilatation and curettage, or gold standard hysteroscopy and biopsy. Need to check the histology and follow up. This is again where if there is endometrial hyperplasia, this is where the place called levonorgestrel releasing intrauterine system plays a major role. This is the how the insulin resistance and how a flow chart to manage. And concluding concluding facts will be that polycystic ovary is not just symptomatic treatment. It is we have to treat the entire spectrum, the causative factors, so that the outcome will be better. And even if you have a busy practice, you should have a mechanism to encourage the patient for a healthier lifestyle and to do exercise. And the patient should be aware of what is good and what is bad to eat. And the treatment has to be individualized depending on the body mass index and medical conditions. Ultimately, we as obstetricians or whoever manages this patient should not make her a cardiovascular disease patient for the cardiologist to manage or with multiple severe medical conditions where a physician has to manage continuously. Thanking you. Thank you.
Thank you, sir. Our sincere gratitude goes to Dr. Mithree Chandrarathna, Consultant Obstetrician and Gynecologist, Chairman GMO Election Committee, and GMOA Specialist Transfer Board member, for his excellent lecture and his precious time. Like I mentioned before, you all can post your questions in the chat box along with your email address, or you can email them to us. Your questions will be answered within the next 4 days. I would also like to thank all our participants for joining in today. You can find the link in the chat box and kindly give your feedback, answer the post assessment questions, and you can receive your e-certificate for participation. I would like to again thank Dr. Mithree Chandrarathna for his valuable contribution for the webinar series. Hope you all had a productive session today. Please join with us next week for another timely topic in our webinar series. Thank you. Hope you have a pleasant day and Merry Christmas.